Hello, dear friends and dear colleagues. We continue to analyze this very complicated clinical case, and now we proceed to the next part of our work, the planning of the treatment. What do we mean by this? We have already determined the distal bite in this patient, have already found the presence of DMD, dystrophic degenerative diseases. We found out not only that one disc is to be prolapsed with dislocation, but there is a block in the joint. We understand why the jaw deflection occurs, so that we have a full grasp of patient condition and possible consequences, including occlusal, for our work. Also, we have assessed the neck status and its muscle dysfunction, so some part of our work we should delegate to other specialists. Necessarily is to have a neurologist if there is a neurofacial pain syndrome. Once again, colleagues, dentists don't treat pains. The most common reason for pain is caries, so this we can handle. Other diseases like neuritis, neurology or rheumatology are not our responsibility. So, you always must involve related specialists. Whatever it was, we have to move on to solve that pool of existing problems. I briefly outlined the cephalometry assessment. It gives us not only the static material of what the bite has patient or the position of the patient's jaw, or the information about bite height, but also the information about treatment simulation and planning the treatment. Thus, if we assess the bite height of this patient, we will see the norm data, especially for this type of the bite. So we have to work carefully while increasing the bite height. Why am I talking about this now? Because for us, the first stage, a pre-prosthetic treatment, is a highly important stage. We cannot immediately proceed to the permanent and even temporary prosthetics to the patients with pains and intra-articular damage. We have to work out a certain treatment conception with the use of spleen therapy. What does the spleen do? Increases the bite height. If we increase the video of this patient, what might be? Look, the teeth practically are set in second class. When increasing the video, the situation becomes worsened and the jaw moves even more distal. Thus, we degrade the situation, whereas we decide to treat it, make a splint, and help the patient. One more important question is the position of the occlusal plane, because if the occlusal plane is set quite steep, it causes the interference in the back areas. So, our task is to calculate the angle of teeth occlusion and to move on in accordance with this data. Because we can change the occlusal plane one way or another, and the teeth rows will change as well. And pay attention to the situation in the oral cavity, assessing the cephalometry in parallel. Tooth 1.7 is extruded, and you see that the distance from the needed occlusal plane has changed. It is related to lower tooth loss in the past. So it is an absolute certainty that there will be provided a prosthetics to these teeth to change the occlusal plane angle and to get these teeth straightened. The same situation is to the left side. This is how I provide the calculations, and for this analysis we use a sagittal condylar path angle as well. But if we take a look at the right joint, we will see that this angle is too steep. And if you don't forget the stages of our diagnostics, you'll remember the MRI picture with the scheme of axiographic tracks, and you'll understand that this steepness is associated not with the tubercle expressivity, but with the disc prolapse. It is crumbled. Most likely, the adhesion occurred as well, so when the condyle moves along the tubercle, it abuts the soft tissues, drops and blocks itself. And we don't see the contour path angle, but the angle which was formed by the crumbled disc tissues on which the condyle is blocked. So this must be taken into account when calculating something. That's why I use the data taken from the left joint but not 70 degrees and then provide the calculation. Also look, I increase the video and the angle SNB has also increased. That is strengthening of distalization. Again, the analytics must not be built on that we have to do a splint, mouth guard or any other construction to set into the mouth. No, we must calculate the possible consequences of our work. So here it is absolutely understandable that we can't only increase the bite height. Our goal is to provide the anterization with a contour rotation, changing both the angle of the occlusal plane and the jaw relationship. It is a position in which we make the splint. We mount the models on the articulator. With the help of a special plate, we provide anterization of the lower jaw. And based on this data, I decided where to do a splint, the lower or upper jaw, because the angle may change due to these moments. We make a splint. I adjust it via the articulator, providing all the movements. I turn over these models. It is a lower jaw to easily make the tracks. After that, I correct it in the oral cavity. If it is needed, I add some composite. I use Primo splint material, and it allows me to do it quickly, handy, and sighted. And pay attention, as you remember, we provided an extensive diagnostics at the initial stage. It was of crucial importance, once again a crucial importance to observe all records and document. I don't consider myself as a pedant, but this kind of work forces me to be, because further you may need to look back, but there will be nowhere to look. If you've documented all the data, so you understand that the patient had pain syndromes, restrictions, deviations or deflections, hypertonicity, and after making and modeling a mouth guard, within 2 weeks you may see the situation to change radically. We see before and after, the re-examining in 2 weeks, and we see there is no pain at all. I tried to show it here. We ask patients to describe it by themselves. Do you remember? 7 to 6 points. It's like the blow of a hammer on a finger. Such extensive headache, neck pain, pain in the legs and back. And now there is no pain at all. It seems to be we do a little bit provocative tests. What if the patient lies to us? The range of provocative tests allows us to control the patient. And here we see that after 2 weeks there is a decrease of specificity and pain matters. And now when we compensate the patient, we can proceed to the next step, to the new temporary prosthetics. We understand that the bite height, there should be jaw relationship, how to provide anterization, and that's what we need to do. But this patient is highly complicated. She doesn't permit us to the total prosthetics, but only the back teeth. Of course, later she admitted she liked the work and got the test. She understands there will be no pain, and we finished the work with the front side, which complicated the prosthetic work. Because if we plan it all at the initial stage, we can work with the gums. It's zenith in advance. The range of work while anterization, how to increase the vertical dimension of occlusion within the framework of her bite. We didn't have the opportunity to review this in advance, and we didn't have the understanding we have to do prosthetics of the front teeth in future. That's why we were restricted in our work, but there is a long-centric technique about which we'll be talking a little bit later, and it allows us to solve this problem without total prosthetics. So, again, the phasing. First, the diagnostics overview. The spleen therapy and re-examining after it. The temporary prosthetic stage and its assessment. And the permanent prosthetics. It allows you to avoid numerous mistakes, to solve a lot of problems, and to provide a successful and long-term prosthetics. In our next video, I'll show you the work with the permanent prosthetics, and we address all stages of the temporary prosthetics work. Thank you for your attention. You're always welcome. Please subscribe to our channel, like our videos, and ask the questions. We'll strive to make some short videos in response to address the cases. I hope it will help you and your patients. Thank you for your attention. There will be a new video soon.